So this is a immediate load case. Patient's name is Kathleen. We took a trios at her initial examination so you could kind of see what's going on. And her chief complaint was, my teeth are loose and I can't chew. So Kathleen is a 60-year-old female. She's got some medical problems: high blood pressure, asthma, rheumatoid arthritis, artificial hip, recurrent headaches, and she smokes at half a pack a day. I tell all my patients that smoke that they need to stop smoking. And if they don't, that I cannot guarantee that something's not going to go wrong. And in her case, she would leave the office, tell me she quit smoking, and because I could see out my window, she'd go to her car and she'd light up a cigarette. Like the day of surgery. Her chief complaint is, my teeth are loose, I can't chew, I'm extremely afraid of dentists, and I want to discuss implants and other options. So her case is going to be fully guided, immediately loaded in the mandibular arch, and her lower arch is going to be a locator fixed. Her maxillary arch is going to be freehand, immediately loaded by smart conversion, and her final prosthesis is going to be a screw retain restoration. So every patient that comes into our office, we go through the same routine: medical and dental history, chief complaint, oral cancer screening, TMJ, muscle palpation, assessment of centric relation and centric occlusion, charting of the dental conditions, periodontal assessment, and depending on the case, we take a PanRx, a CBCT, or an FMX. On a patient who we don't know if she's going to go forward with implants, who has teeth, we usually start off with an FMX until we determine, before we radiate her with the 3D cone beam, so that we can evaluate the bone and the implant positions. So for her periodontal assessment, she had pockets of 4s, 5s, 6s, 7s on both arches. The lower wasn't quite as bad as the upper, but her front 4 teeth were severely mobile. I called it a 4. When she closes her teeth together, the teeth splay out in a 45-degree direction. Charting-wise, she had decay pretty much on all of her teeth, period disease on all of her teeth. And here's the pre-op PanRx. So let's use our own this case philosophy. So going back to this, we don't want to just look at the quality of the bone and the vital anatomy. We want to do everything prosthetically driven in terms of placement of the implants, because we need to know where the teeth are going to be before we plan the implants. Because take a case like this, if we sent the models of a patient like this with no pictures and said plan some implants, they're not going to know where those teeth should be unless they have a photo, or unless I send a model and show them where I want the teeth to be. So if implants were planned on a guy like this, you might have the implants end up too high and not have enough restorative space when you put the teeth in the proper position. So let's follow my little chart that I developed and start with the case workup. So for our case workup, we want to take photos, we want to take videos, we want to take intraoral scans, and we want to take a CBCT. And we want to put all this information in that and create a virtual patient. So a really fantastic product that's really developing fast, and I'm not going to be able to live without it as soon as they put the final touches on it. It's called SmileCloud. So SmileCloud, we create our virtual patient. We could put all this information into a software where all the team members of the interdisciplinary team can access it. Everyone can put in their own their own information. And also with this program, we can do digital design to do designs of mock-ups so the patient can see what they're going to look like, so we can propose, a smile for them. We can send these mock-ups, these little designs to the patient within their face so they can kind of get them excited about the case. And in the very near future, you're going to be able to port these 2D designs into 3D to send them to ExoCAD or send them into 3Shape so that you could use what you designed clinically and show the patient as part of the design of the prosthesis. So every person of the restorative team could add information to this chart. When you create a file, what the person who starts the case can do is send an email to each person they want to be part of the team, and they can have their own account and access all of this information. And this is really what I call interdisciplinary teamwork, because again, we don't have to meet physically, we can do all this planning online. And so you set up your account, you invite the members of your team to join. And then we can put all of this information into that chart. We could take the videos so that the team can look at the video. We can put our STL files. We can put our CBCTs and view them. How many of you get CBCT files and you try to open them and you can't, and then you call your surgeon and they say, okay, I'll send a different version. And so in this Smile Cloud, you can view these CBCTs. And you can put your final results of the case so that you can just keep a file with everything in it. You can use this to do crown lengthening guides for anterior aesthetic cases. So it's really limitless as to what you could do with this software. Okay, so let's start with photos. So when I take my initial photos, I want a photo of the patient with their lips just slightly apart. I just ask them to say the letter M and let your lips slightly separate, because I like to see if they have any incisal show when they're at rest or in repose. Then I ask them just to give me a nice natural smile, and they're usually not wanting to smile that big. And then I have them do that exaggerated, say the word E and exaggerate your smile. A side view is always nice because it helps us evaluate the anterior posterior position of the teeth so that we could decide if we need to change that in any way. We like to see the edges hit the wet-dry line on the lower lip. And other images also can help you during your treatment planning so that you could just see different views of the patient. This 45-degree view is really good because it really tells us where that incisal edge hits on the lip and helps us to make decisions if we want to move those teeth back or forward. Here's the intraoral photographs of our patient. You can see decay everywhere. You can see the splaying of the teeth. You can see how her teeth come forward when she closes, and you can see that she's got generalized periodontal disease. And for the reason of the mobility of the teeth, go back again. Because of the mobility of the teeth, it's impossible to even take an impression to do this in an analog fashion, because the impression material alone is going to displace those teeth. So that's why I did a digital scan on her. Also, we know that we really can't do this. We really can't do this case guided because no impression will allow us to make a guide that will fit on these teeth that are moving around. So that's the reason we decided to do that freehand. But in the mandibular arch, your teeth are a little more stable, so we're going to do a guided case in the lower arch. just a few more photographs. You can see how her teeth used to be splinted there, but because she's got no posterior support, she broke that splinting, and that's why her teeth are so mobile right now. The next thing we could add is the videos. Again, the videos are going to give us even more information. If the patient's not smiling big enough, we can get them to laugh. We could look at how the incisal edges hit the lower lip. We could look at her high smile line. And sometimes if I don't get a good photograph, I'll take a still shot from a video, stop it and take a screenshot, and I'll send that photo to the lab instead of another photo if I think it's not really adequate. We can evaluate the closest speaking space to see if their vertical looks open or closed, or if they have a slushy type of an S sound. Now, we didn't do a CBCT yet at this point, but this could be a Panorex, it could be a CBCT, and it could be a full mouth series. And lastly, we did some intraoral scans. Okay, so I did have to make a immediate denture so that I can convert this on the day of surgery for the upper jaw. And so I don't like using scans for my digital for my dentures because it doesn't capture all of the anatomy, the retromolar pads, the hamular notches, the vestibule is very good. So I wanted to take an analog impression. So what I did was I just put some composite between those teeth, pushed them together, cured it, and that stabilized it enough that I could take an alginate impression good enough that I could make an immediate denture on. But she doesn't have any posterior teeth, so we have to make a base plate and a wax rim so we could mount the case, determine vertical dimension of occlusion. We'll contour our bite rims, determine the vertical, take a bite registration, a face bow, and mount the case. Now again, I want to, so that the lab can plan my lower locator fixed, I want to determine where those upper teeth should be so they can plan the teeth to fit against what's going to look good aesthetically in the upper jaw. And so I grind the teeth off of that upper model. I set my teeth by looking at the patient's photographs to where I think would be a good incisal edge position. And then we're going to also use this to create a clear duplicate to help us at the time of surgery. Again, just like that first case, we have to leave that lower model untouched in terms of the existing teeth because we're going to make a guide that fits on top of that. But when I'm setting my upper teeth, I don't like to set them to air because you could get a discrepancy in the buccolingual position or even the vertical position. So I set a couple teeth on the lower just so I had something to follow when I was placing these upper teeth on the model. And there's areas where you can't really, some super eruption over here, so I had to leave a little gap here. But before we process this denture, we'll close all these spaces and more idealize this plane of occlusion. So there's the setup before it goes to the lab. Establishing our occlusal plane with some denture teeth on the bottom. And this is that SAC program from ITI. I just wanted to give you a little more in-depth interpretation of it. So it takes you through a series of steps necessary to identify the degree of complexity and the potential risks involved in the implant dentistry case. And it provides you objective input as to whether this case is straightforward, advanced, or complex. Within this SAC report, they also have just a paper instead of having the electronic one, where you can look at these different issues that you might have, and you could circle for each point what you have, so you can see if the risk is high, medium, or low. So just a little quicker, simpler way to do this. But if you look at the electronic part that you can go through, just to show a couple things that they ask about, like whether the patient has occlusal parafunction, and if so, that puts them at a higher risk. If it's a upper all-on-X type of case and the patient has a high gingival display with their smile, you know you're going to have to be a little more complex in terms of your treatment planning so you don't have a transition line problem. So that would tell you if you have a low or a high risk. General assessment, it talks about whether they're smokers or not, the anatomy, whether they have a lot of keratinized tissue or whether it's all mucosal tissue, will tell you the risk of periodontitis around the implants. And then some of the prosthetic factors, the prosthetic volume, interocclusal space. So all of these things you can answer very quickly. It'll tabulate all this. It'll put it in a little summary that talks about the high-risk areas and tells you whether you have a difficult or a simple case. So just a great tool. And again, a great legal record that shows that you really thought about this case, evaluated this case in every aspect.